Yes, sir, you can start now.
Thank you. Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at MCure Pharmaceuticals. We at MCure are proud to present Cardio Colloquium, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected moderator, Dr. K. A. Sambasivam, sir, Chairman Cardiology and Senior Interventional Cardiologist at Department of Cardiology, G. Kuppuswamy Naidu Memorial Hospital, Coimbatore. He is Associate of American College of Cardiology, Fellow of European Society of Cardiology, Asia Pacific Society of Cardiology, and CSI. He is permanent member of IMA, CSI, and Pediatric CSI. Sir has participated as chairperson scientific session in Tamil Nadu chapter CSI annual meet at Vellore in 2003. He participated as invited faculty in Kobe, Japan, advanced course in interventional cardiology meeting Tokyo 2008. Participated as faculty in Asian Interventional Cardiovascular Therapeutic Conference, New Delhi in 2012. He is recipient of prestigious Distinguished Service to Community Award by IMA Coimbatore chapter and Indian Association of Clinical Cardiology, Tamil Nadu chapter in 2014. Sir has participated as principal investigator and investigator in landmark clinical trials like Appraise 2, Tracer, and other landmark trials. Sir has numerous publications in journals and paper presentations in various conferences. It is an honor for me to introduce our expert panelists for today. We have Dr. Kalai Chelvan sir, Senior Consultant Cardiologist at MMM Hospital, Chennai. We have Dr. Ramakrishna Kumar sir, Consultant Interventional Cardiologist and Electrophysiologist at Narayan Hrudayalaya, Bengaluru. We have Dr. Anand Pille sir, Consultant Interventional Cardiologist and Electrophysiologist at Anand Puri Hospital, Trivandrum. We have Dr. Suresh Yera sir, Consultant Interventional Cardiologist and Heart Failure Specialist at Star Hospitals, Hyderabad. Thank you all the faculty for joining. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the keynote session on optimal selection of RASI in post-MI patients by Dr. K. Sambasivam sir. The meeting will proceed further with the panel discussion where Dr. K. Sambasivam sir will drive the panel discussion. I request audience to put their questions in the comment box so that we will take up those questions in the end. Now I would like to invite Dr. K. Sambasivam sir to deliver keynote session for today. Over to you, sir.
Thank you, Dr. Rishikesh. Good evening to all the panelists. Can you just start sharing the slides?
Yes, sir. I'll share.
Yeah, thank you. I think I should, at the first instance, congratulate the MCure for this academic endeavor, which is very, very relevant. We know very well that the renin-angiotensin-aldosterone system plays a pivotal role in LV remodeling post-myocardial infarction, and we have a number of trial-based evidences to show that RAS inhibitors do have a clinical effect benefit in terms of reduction of all-cause and cardiovascular mortality and future cardiovascular events, especially in patients with large MI, anterior wall MI, patients with LV dysfunction, patients with diabetes, chronic kidney disease. And so the next few minutes, what I'm going to discuss is what is an overview of these RAS inhibitors in post-MI patients. So how do we go about in choosing which type of RAS inhibitor in post-MI patients? Can I have the next slide? Yeah, I'm just starting with the two-patient scenario. On the left of the slide that you see is a 68-year-old gentleman who had presented with an acute interval STEMI, who was lysed with the tenactiplase and subsequently was taken up for an invasive evaluation and underwent PCI to proximal LAD. Subsequent echo prior to discharge revealed an ejection fraction of 30% and a regional wall motion score index of 1.6. So he is been, while in the hospital, is put on metoprolol 25 milligram, uh, of course with ticagrelor and aspirin. The combination of high intensity atorvastatin with ezetimibe and eplerenol. Can I have the next? Yeah. So, what shall we add to this patient in terms of RAS inhibitor? Ramipril 2.5 milligram twice daily, or perindopril 2 milligram, or valsartan, or an orni. So that's quite a point of interest that we are going to have in the next several minutes. On the right, we have a patient who is 49 years old, presented with an acute coronary syndrome and diagnosed to have an STEMI, undergoes an angiogram, found to have a two-vessel disease, 40% LED, and intermediate disease of the OM. Ejection fraction was 50, and the wall motion score index was 1. So basically, we are dealing on one side a patient with a large MI post PCI and having an LV dysfunction on one side. On the other side, patient with an acute coronary syndrome, NSTEMI with a fairly preserved ejection fraction and with on medical management because of intermediate coronary disease. On the right, we have the patients who is put on again DAPT, high intensity statin with ezetimibe and beta blocker. Can I have the next slide? Next slide, please. Yeah, thank you. So whether this patient requires to be put on ramipril or an ARB like losartan or telmisartan or valsartan. So that's a debate that we are going to have, and evidence to show which drug we can place. Next slide, please. Coming to the overview. Yeah. So what I'm going to do is I'm just to point a few evidences for each of these molecules, RAS inhibitors, the ARBs, the ARNI, and AC inhibitor post-MI, and then let's see what the guidelines suggest. Next. Next. Yeah. If we go by the evidence for recommending an angiotensin receptor blocker, we have two trials, basically one on losartan and one on valsartan. Both had patients who had a large MI with evidence of heart failure. In the optimal, it was losartan, which was started at 50 and went up to 100 versus captopril, which was the then AC inhibitor, which was widely used way back in early 2000. And the other one is on valsartan, wherein valsartan and ARB was compared with captopril. And then they looked at the effect of combination in patients, about 14,000 patients post-MI. Next slide, please. Can you hear the next? Yeah, thank you. So what we found was in the optimal, compared to losartan, captopril has a non-significant better primary endpoint effect. And you can see the secondary endpoints are all statistically non-significant, but with a little favor to captopril. So the outcome was that losartan cannot be generally recommended in this population, and AC inhibitors should remain the drugs of a choice among the RAS inhibitors post-MI in this group of patients. Next. Coming to the Valiant trial, which I mentioned, looked at comparison of an ARB valsartan versus captopril, and then the effect of combination versus captopril. What they found is, as you can see, the curves, excuse me, the mortality from any cause and cause-specific mortality were similar in all the two treatment groups. And the individual endpoints, cardiovascular death, MI, or heart failure by treatment, again, was not significantly different. And what it went on to find was the combination was detrimental in terms of the adverse effects. So the outcome of the trial was that valsartan was non-inferior to captopril, and the combination is not advisable. So that's the effect of the conclusion of the trial. Next slide, please. Of course, we did have a few trials on other molecules. I'm not going to go into the details. Predominantly, the post-MI, these were the two. Coming to the ARNI, the drug of the decade, I would say, for heart failure, which was outcome of the Paradigm HF trial, which showed the efficacy and superiority of the ARNI over ACE inhibitors. In fact, there's only one randomized trial which made a class 1 recommendation by all these societies. But the effect was only predominantly in heart failure. But subsequently, they looked at effect of ARNI versus ACE inhibitor, the same molecule, which was looked in compared in the Paradigm HF in the Paradise MI trial, which was presented way back in 21. So they compared the ARNI versus the ACE inhibitor. Next, Ramipril. Next slide, please. Yeah. So this was the flow of the trial, where they recruited patients within about 24 hours to about a week after an MI with evidence of pulmonary congestion or LV dysfunction of EF less than 40 or equal, with another risk enhancer. Can be age, decreased GFR, presence of diabetes, past MI, or CLIPS class 3, or a STEMI without reperfusion or presence of atrial fibrillation. Patients with the prior HF or clinical unstable patients were not included, and so were patients with the EGFR less than 30. So they compared the standard dose of ARNI versus the Ramipril standard dose, which was tried in the post-MI trials as well as the HOPE trial. So this was an event-driven trial, and the primary endpoint was this. Next slide, please. Yeah. What they found was, though there was a numerically lesser event rate with the sacubitril valsartan, it did not reach statistical significance. Even though this was a kind of a trial which was a negative in terms of their benefit of ARNI over and above Ramipril, they did a exploratory subgroup analysis of clinically adjudicated events, and they found that there was a statistical significant composite primary endpoint with sacubitril valsartan over Ramipril, though it was not the primary primary endpoint in the overall group. Next. So next, when they looked at this outcome, you can see that the hazard ratios, both sides of the unity, and p-values are not statistically significant except for outpatient heart failure. Next. Of course, the cough was more with the Ramipril group, and the hypotension was more with the ARNI group. Otherwise, the serious adverse events were quite comparable. Next. So the summary was the primary the aim that what they tested was to show the superiority, which did not result in a significantly lower CV rate with sacubitril valsartan. Of course, the pre-specified observations of reduction in the investigated report outcome as well as the total were supporting, as I mentioned. Safety and tolerability was comparable. So because the effect was not favoring statistically in the overall group. Next slide. Yeah, these were the media repercussion of the Paradise MI trial. Sacubitril valsartan can't beat Ramipril from the Medscape. From the ACC, the headlines, they can say that ARNI did not outperform ACE inhibitor post-MI. it makes the Paradise MI makes a question of benefit of sacubital valve and so on and so forth. RNA does not surpass ACE inhibitor after acute MI was a TCT media show. But then subsequent to this, we had a couple of systematic meta-analysis and network analysis, which were published in American Journal of Medicine and as recently as in Biomedicine Journal, where it was found that there was a significant relative risk reduction when you compare RNA versus ACE inhibitors. So that's a current scenario, but then it has not been translated to the guideline recommendations as of now. Next. So coming to the time-tested molecule, the ACE inhibitors, we have evidence for both high-risk patients post-MI and long-term effect, as well as short-term broader MI group of patients. Next. This was a first trial which showed efficacy post-MI in patients with elbow dysfunction on capital, where you can see that there is a 20% reduction in all-cause mortality and 25% reduction in recurrent MI with the curves diverging. Next slide. Yeah, again, similar outcome with the Trandralopil, starting with 1 and going up to 4, followed for about close to 50 months, 25% reduction in mortality. Next. Yeah, broader group of patients again with captopril and lisinopril and captopril showed that there is a survival advantage with the ACE inhibitors in broader group of patients post MI. Next. Yeah, coming to the particular molecule, ramipril. This was a trial which really made a huge impact in the placing the ramipril post-MI scenario, acute infarct ramipril efficacy, which was published way back in 1993, wherein post-MI patients with transient or persistent heart failure who were randomized between 3 and 10 days, and with the oral ramipril of 5 milligrams twice daily over and above the standard of care, showed a 27% reduction in mortality. As you can see, that curve started diverging as early, with a 19% reduction rate of MI and stroke in 6 months. Significant p-value. Next. Subsequently, after the study period was over, there's a UK group which had a extension of the effects which were looked into the patients who were earlier on ramipril, and they were followed up for about almost 60 months. And what you can see is that the survival was better, and there is a relative risk reduction of 36% with the ramipril over the next 5 years, even after the primary eye trial was over and the drug intake was over. So, which gave a conclusion that the treatment of 9 patients with ramipril for an average of 1 year will result in 1 additional survivor to 5 years. So that is the benefit that you get with the use of ramipril post-MI. Next, then they looked at the long-term survival called IRE survival, which again looked into the same UK group where they were followed for about 29 years, close to 30 years, and they looked at the impact and the magnitude of impact on length of survival observed after treatment with ramipril at the dose of 5 milligrams twice daily when compared with the placebo. Approximately 30 years of follow-up in the same group, which were initially the cohorts in the eye trial, UK cohorts. Next. This was published in the Heart Journal. What they looked at, the median survival time was 8.3 years in the placebo group, whereas it was 9.6 years in the ramipril group, with the extension of life of 14.5 months. As you can see, the red one with the ramipril and the blue one with the placebo, up to about 15 years, the benefit was seen after starting the ramipril post-MI period, and the life expectancy was greatest at about 15 years, after which the curves crossed, and maybe because of the subsequent events, after the 15 years, the curves were almost identical. What it went on to say was the life expectancy was improved with the ramipril, and it was seen across all groups. Next slide. The maximal effect was seen in diabetic patients, where you can see this. The benefit was in favor of ramipril. Patients with past MI, the patients with history of heart failure, hypertension, patient with angina. You can see in all these groups, the efficacy of impact of length of survival was seen with the use of ramipril on a long-term follow-up. Next. Yeah, so what overall, for every day a patient received ramipril on average, life was extended by further a day. So this was a take-home message from the IR survival long-term follow-up trial. Next study. Yeah, this was the result. Next. That was a concluding remark. Treatment with ramipril for about a year post-MI early, when it started early, results in survival benefit which is sustained over many years, and on average an extension of life of an additional 1 year, which is a huge. Next. Yeah, which AC inhibitors choose? We know very well the AC inhibitors have a definite role. Which one of the is the class effect? There was a paper from the Canada, which was published in Annals of Internal Medicine, where they looked at different molecules like enalapril, fosinopril, captopril, quinapril, and lisinopril, and perindopril and ramipril. And what they looked at, the post-MI patients who were elderly, or above 65, they looked at the 1 year effect. And the conclusion was survival benefits in the first year after acute MI in patients 65 years of older seem to differ according to the specific ACE inhibitor prescribed. Ramipril was associated with a lower mortality compared to other ACE inhibitors. This was from this Canadian study. Next. Yeah, subsequent recent data, registry data from the Korean acute MI registry called KAMIR NIH, compared the RAS inhibitor effect on the long term after 1 year of use. What they found was a bit different, that they didn't have a survival benefit after 1 year of use of RAS inhibitors post MI. Even and when they compared to AC inhibitor and ARB, what they found was there was a uh, uh, little significant benefit with AC inhibitors compared to ARBs, especially in terms of cardiovascular death. Coming to the second case scenario, which I mentioned, ACS non-STEMI with a preserved ejection fraction. We have trial evidence with these studies we have wherein patients with post-MI were recruited. And the studies have shown that there is a benefit in terms of improvement in the LV remodeling and certain anti-atherosclerotic properties and plaque modifications with these RAS inhibitors, ACA and ARBs, which can be useful and so can be used in all comers of post-MI. Next. So what do the guidelines say? Next. This was an overview. But the idea is very clear. Post-MI heart failure, start the ACE inhibitors very early, as early as within 24 hours. In fact, it was shown that 40% of the benefit was obtained in the first 24 hours. Next. Yeah, the maximum benefits were seen within 24 hours. Next slide. So ACI should be administered within 24 hours for heart failure post-MI period with the ejection fraction of less than 40%. Early initiation is very, very important. Next. So as a result of these trial evidences, 2020 ESC guidelines gave a class 1A recommendation for ACE inhibitors and ARBs in patients with heart failure, by whatever be the cause, even post MI. Next, the 2025 ACC-AHA guidelines again gave a class 1A recommendation for AC inhibitors or ARBs to reduce all-cause death and MACE in patients post-MI. And in patients with ACS who are not considered high risk, like the patients with a second scenario which I gave, an oral AC inhibitor ARB is reasonable to reduce MACE. The RNA was not found in the both the guidelines. Next. So also in summary, AC inhibitors among the RAS inhibitors remain the gold standard post-MI drugs. ARBs can be used if the AC inhibitors are not tolerated. RNA is emerging, but still not got the guideline recommendation. But whatever drugs we use should be started very early. Next slide. So with this, we will move on to panel discussion. We have an excellent panel with us, Dr. Kalai, Dr. Ramakrishna Kumar, Dr. Anand Marthanda Pillai, and Dr. Suresh. So let me start with the few questions to Dr. Kalai. In patients post-MI, especially post-revascularization, post-PCI, I would say, what level of systolic blood pressure you initiate AC inhibitor? I was mentioning about the earlier start, and there were some couple of scenarios wherein you have to take care of the blood pressure. So what is the starting blood pressure you would like to initiate AC therapy, and what is the starting dose, and how do you up titrate? Dr. Kalai, please. I think you're muted. Yeah. Dr. Kalai. Dr. Kalai, are you with us? Rishikesh?
Yeah, Dr. Kalai, can you hear us? Please unmute yourself.
Nisar, can you please check whether if doctor is facing any issue? Sir, Samsivan, sir, simultaneously we can take with the other faculty if he's, I think.
Yeah, sure. Okay.
Yes, sir.
While we are waiting for Kalai, I would like to move on to Dr. Ramakrishna Kumar. Can you move on the slide, please?
Okay.
Yeah. So a patient with an hypertension who has been on an ARB comes with an acute MI, and then you do a primary PCI. And do you switch this patient to an ACE inhibitor after this procedure, or would you be continuing the same ARB? Dr. Ramakrishna Kumar.
Thank you, Dr. Sambasio. So I think as of now, we can safely say we don't have an evidence to answer this question, because I don't think we can ever have a trial to stop a drug and then restart Tenera in these situations. But we can probably derive most of the data from all the pre-existent trials. The guidelines clearly states that ACE inhibitors or ARNI, in this case now ARNI is not yet come into form for MI, be the first choice and ARBs as the alternative drug. Because ARB has never shown to be superior to ACE inhibitors in both the trials. In the Valiant trial, the valsartan was almost same as the ACE inhibitor. Losartan was not shown to be superior or slightly non-inferior to the drug. So as of now, ARBs are not superior to ACE inhibitors, certainly. So apart from the guidelines trials, other thing is more hypotension associated with ARB. Some of the randomized trials also show some renal dysfunction with ARBs also. But that said and done, when they compared most of the trials, be it in MI, be it in patients with high risk of cardiovascular events, patients with different comorbidities like diabetes, CKD, elderly people, ACE inhibitors and ARBs have shown to perform almost similar. There's not much difference between the two drugs most of the time. Though clinically the guidelines are stuck on to the point that use ARBs only as an alternative and ACE inhibitors cannot be used. That's what it is. Theoretically, ARBs are supposed to do better because they act at the receptor level, so that they can take care of other sources of angiotensin also. At the pathophysiological level, they're shown to reduce macrophage infiltration, MCP, and reduce the fibrosis. But in clinical effect, it has not translated to over an extra benefit over an ACE inhibitor. So that said and done, when somebody who has got hypertension on ARB and is remained stable and the medicine has worked very well, it becomes difficult to decide what to use, whether shift to a guideline specified ACE inhibitor on ARB. Probably I would stratify this patient as a low risk or a high risk patient. High risk, I would consider somebody with significant LV dysfunction, heart failure, having multiple comorbidities like AF, CKD, diabetes. Such a high risk population, I will tend towards more of an ACE inhibitor. Though at this point of time, it would be inappropriate for me to focus on ARNI. I think Paradise MI trial was not done fully well because there was type 2 errors and it was underpowered. And even when in the Valiant trial, the event rates with Ramipril was actually 20%. But if you look at the Paradise MI trial, the event rate with the Ramipril was significantly lower. It was probably only some 8% or 2%. So, the other therapies had significantly reduced the mortality level. So it's a very probably not early. It's too early to say that ARNI is not helpful in MI. I'm sure we will get much better trials and ARNI in the future will certainly replace ACE inhibitor. So, but if we compare ACE and ARB in the setting of high risk, I'd probably tell towards an ACE inhibitor. But if somebody who's low risk, somebody who's EF more than 50, not significant comorbidities, has been stable on his sartans, probably I'll continue sartans. The other evidence which is not with sartan is, as said, the trials have been compared only with valsartan and losartan. Most of our present patients will be telmisartan, losartan to a certain extent, and olmesartan. Now, these are not the sartans which have been conventionally tried in MI trials. Though they have been tried in part of hypertension trials or stroke trials, they have not been conventionally studied in an MI trial. So it will be slightly difficult to extend this to all this. As this article already pointed out in 2000, Watson said, when they compared all the ACE inhibitors, Ramipril was shown to be superior to other ACE inhibitors. ARBs can also have a class effect. Losartan was not superior to valsartan. They can have a class effect. So it may not be conventional to continue them in the setting of a poor LV function. So high risk, I'll certainly tilt towards an ACE inhibitor or an ARNI. Low risk, yes, probably I might still continue with the ARB. That would probably be my answer, sir.
Thank you, Ramakrishna Kumar. It's excellent disposition of your decision on continuing an ARB or changing, which is based on an individual profile of the patient about the risk stratification, and then you decide whether to switch over or not. Very valid point. I think the message is very clear. Moving on to ARNI, you did mention about the role of ARNI, which hasn't come to the guidelines.
Yes.
Dr. Anand,
Yes,
if suppose you're off-label, you would like to start on an ARNI, how early do you think an ARNI can be initiated post-MI? Do you advocate or do you advise, or you still would like to wait?
sure. Actually, we are trying to start RNI post MI, not so much from a post MI standpoint, but more from a heart failure standpoint, particularly if there is at least moderate LV dysfunction. And the choice would have to be individualized depending on patient. The key factors to consider would be the hemodynamic status of the patient, volume status of the patient, as well as the renal function of the patient. If the patient has a reasonable blood pressure, we will be more comfortable starting an ARNI. Obviously, the patient should have recovered from pulmonary edema and cardiogenic shock if it was a large myocardial infarction. And the patient has to be euvolemic and has a reasonable blood pressure. And ideally, in a state where either a normal renal function or at least in a recovery phase from an acute kidney injury if there was initial cardiogenic shock and so on. As we know, ARNI is a vasodilator, both the valsartan as well as sacubitril, both are vasodilators. So that has to be kept in mind as well. Another strategy which we use is we start the patient on valsartan alone at a low dose, maybe 40 milligram BD, and then step it up to 80. And if the patient is tolerating that, before discharge, we might switch them completely to an ARNI. And this makes it also convenient because valsartan is kind of partially adding half of an ARNI and then switching up to a full ARNI dose. And in such circumstance, we actually particularly take care that we start with valsartan itself and not with an ACE per se, because according to the practice guidelines, if the patient is already on an ACE and if you want to switch ARNI, you want to wait around 48 hours for a washout period so that there is no overlap between an ACE and R, or ACE and ARNI, which can cause adverse events. So that is the way I would look at to summarize. If the patient it's a small MI without LV dysfunction, we are not very keen on putting an ARNI up. Because as we had just discussed, in a pure post-MI setting, there has not been a mortality benefit, but heart failure setting, there is definitely a mortality benefit. So MIs with at least moderate LV dysfunction, and particularly clinical heart failure, we try our best to get the patient onboarded on ARNI before discharge.
Thank you, Anand. That's a wonderful exposition. You did mention about what you do normally for heart failure patients, especially starting them on an ARB like valsartan, get the dose titrated, and then switch over instead of putting them on an ACE inhibitor, which, as you mentioned, a washout. This is a scenario where a post-MI heart failure, yes, you said you would probably start, but do you think, you mentioned the patient should become a euvolemic. In a scenario of post-MI wherein the patient is not in clinical heart failure but has got an evidence of LV dysfunction, would you like to start within first 24 hours or would you like to wait, if at all you're starting an ARNI?
If the patient tolerates, from blood pressure standpoint, yes, definitely, I would like to get the patient started as early as possible. Obviously, a few days is not going to make a big difference, I feel. So at least within a few days of the MI or before discharge, as much as possible, if the hemodynamics tolerates, yes, we would definitely like to get the patient on an RA and give them the early benefit. So as we had just discussed, there are multiple axes which we are trying to attack. You're trying to block your sympathetic axis, your renin-angiotensin aldosterone axis, enhance your neprilysin axis, and so on.
Okay,
So,
thank you. Yeah,
yes.
sorry, go ahead. Please go ahead.
Yeah, that was it.
Okay, so it's very, very, very clear point. And during his discussion, Dr. Anand mentioned that if the patient had an MI and there is no LV dysfunction, he'll be hesitating to start an ARNI he was mentioning. So that leads me to the next question to Dr. Suresh. Are you with us? Post-MI, post-revascularization, if you find LV systolic dysfunction is there, the patient is not in clinical heart failure, will you put the patient on ACA or ARNI?
Thank you, sir. Thank you for the question. First of all, it's an excellent talk by Dr. Sambashivan, sir. So this question, if the patient having LV dysfunction but not symptomatic heart failure, so definitely my first, I'll put the patient on ACE inhibitor but not ARNI. If you look into the heart failure stages also, stage B, who are having LV dysfunction but not symptomatic heart failure, there is no recommendation for ARNI. Only we use ACE or ARB along with the beta blocker. So ARNI comes to play only in stage C heart failure when the patients are symptomatic. I think the same rule can be applied even for post-MI patients with LV dysfunction but not in symptomatic heart failure. I would not like to start the patient on ARNI, and I'll wait till the first, if the patient post-MI presents in the follow-up with the heart failure, then that's the correct time to stop ACE inhibitor and switch to ARNI. Yeah,
Okay.
I'm done, sir.
Thank you, Suresh. I hope Dr. Kalai is on. Is he on, Dr. Rishikesh?
Yeah, Dr. Kalai Selvan, sir, can you hear us now?
Nisar, can you please update? Nisar, I think you spoke to Dr. Kalaichalan. Nisar?
Yeah, Dr. Kalai Selvan, sir, please unmute yourself. He has
Is he
joined,
with
I
us?
think.
Is he joined?
Yeah, he's there, but I don't know.
Okay,
Sir,
so
can you
let's.
please unmute yourself?
Nisar,
In
can you update the status? Nisar, hope you spoke to Dr. Kalaichalan. Nisar?
So while we were waiting for Kalai Chelvan to join, just putting a question to all the panelists. What do you think? When do you like to start a post MI patient post revasculation beta blocker on the day one, or if so, what would be the preferred beta blocker, and what dose would like to initiate, and how do you uptitrate, and what do you think about the combo of these two ACE inhibitors and beta blockers? How do you put them in perspective, post MI, post revascularization? Anybody can pitch.
Yeah, I would like to take the answer. So I would like to start the patient on beta blocker if the patient is not congested. So on the pressures are okay, we can start with the low dose beta blocker. And my preferable beta blocker will be short acting, like a beta log or a metoprolol tartrate initially, and then switch to a long acting before discharge. What dose do you initiate? I will start at 12.5 twice a day, and we'll titrate to 25. Subsequently, if the patient is holding on the pressures well and tolerating the beta blocker. And if the pressures are good, yeah, I will advise a combo of ACE inhibitor and beta blocker by the time of discharge.
Okay.
Any differences? We can
No, but I think it's a fairly great point that you had discussed about the choice of the drug, this dose of the drug to start with, and the point that you had driven is short acting. That is very important to adjust the dose in terms of the. In case of a first few days of MI, it's very important to have a short acting beta blocker rather than a longer acting one. Once you get the right dose, you can probably switch over. Comments from Dr. Ramkish Kumar and Anand?
Yeah, so the starting time of the beta blocker, I'd probably start the next day or by the end of the first day, provided the hemodynamics are normal. You have to be careful when some of them have this tachycardia, 120, 130 heart rates. Or there is a tendency to start beta blockers. Sometimes some of them even put them on ivermectin. Now, sometimes these can be very harmful. So that's actually compensatory mechanisms many a time. If you see the pulse pressure low, where the pulse pressure is very low, sometimes it's mostly compensatory mechanisms. So in that case, you should be very careful in trying to cut down the rate with beta blocker or ivermectin. You might sometimes end up doing more harm than what is actually intended. So if the pulse pressure is good and you are sure it's not clinical heart failure, then yes, definitely. And beta blockers have to be started early, but no harm in waiting till the end of the day and then starting the next day. It's not something which needed to be started as early as an ACE inhibitor, but start as early as possible. And by convention, theoretically, it's better to start with a short acting. I think most of us in our practice, sometimes we prefer some of the long actings at a lower dosage and then gradually increase based on our clinical judgment of blood pressure and absence of heart failure. And as far as the combination is concerned, yes, when stable, certainly they can be combined. Only among the drugs of choice, we have evidence mainly only for carvedilol and heart failure. Yes, definitely we have a lot of trials, but most of it is evidence is for carvedilol, especially anti-ROL MA. But I think subsequently both the long-acting metoprolol and bisoprolol are also equally good drugs in the long run.
Thank you, Dr. Ramakrishnan. Very important point you drove that in the initial period, tachycardia, you just can't jump in and put in on a beta blocker, and all the more for ivermectin, which I've been seeing being used by some of the physicians, even in the acute phase, which we do not have a trial evidence for that, and especially when you have a tachycardia as a compensatory situation, you have to be careful to start on ivermectin. That's my viewpoint. Dr. Anand, your view on this beta blocker?
Usually what we do is we start with, so obviously the patient shouldn't be an overt heart failure, pulmonary edema, cardiogenic shock, then obviously you wait until they recover from it and the inotropes are weaned off, and you wait for at least 24 hours after the inotropes are weaned off to get them on one of these blockers. So on the other hand, if there is no hypotension, if there is tachycardia, as you have to be cautious, as was discussed, if it's a compensatory tachycardia, particularly if there is severe LV dysfunction, then you want to be careful. There is only mild LV dysfunction, but there is relatively heart rate is on the higher side, let's say 90, 100 or 110. I do feel comfortable starting a beta blocker. We usually start with 25 of metoprolol TDS, and then slowly either BD or TDS, and then to metoprolol 50 BD. And then by the time the patient is getting for discharge, we switch the patient to extended release beta blockers. My comments on ivabradine is, as we know that ivabradine as such is a direct sodium pacemaker channel blocker only, and therefore it selectively reduces the heart rate without causing any negative inotropic effect, which the beta blockers cause. Ivabradine is kind of a safer drug in this scenario. And oftentimes, I think, particularly in the state of there being only mild LV dysfunction and the patient is tachycardic, is usually as a result of a sympathetic overreactivity or in the acute phase when the patient is settling down, also from the pain and distress of the MI and so on. Such a scenario, I actually think that ivabradine could be useful from a more of a hypothetical standpoint, because we don't have any trials looking at it per se. But we know that post-MI, you have wanted to reduce your cardiac demand. And if you're able to bring down the heart rate slightly without having a negative inotropic effect, it's desirable. So honestly, I do use ivabradine sometimes in this particular scenario where there's only mild LV dysfunction. There is kind of patient is very tachycardic in the post-MI scenario. We do start with ivabradine for a day or two, and actually once they have settled down, I switch to a beta blocker. I don't continue the ivabradine as a post-MI treatment as such, but the first few days, in order to reduce the cardiac demand by selectively reducing the heart rate, I do use ivabradine, and obviously that is off-label.
Very nice way you argued of favoring your temporary use of ivabradine in acute MI scenario. And of course, you did mention the use of beta blocker, the type beta blocker and all that. So a question to both of you while we are still waiting for Dr. Kalaiselvan. I don't know whether he's still joined. In
Sir, sorry for interrupt you, sir. Dr. Kalaiselvan, just now I got a message. He was in emergency. He just conveyed a message that he couldn't be able to participate as of now. I tried to connect, sir, because he is in the emergency, sir.
No worries. So let me take the liberty to ask any one of you, if you are starting an ACE inhibitor post-MI, and you mentioned that early we should start, what post-revascularization, what level of systolic pressure would you be okay to start with? And then what is an up-titration strategy you would like to have? A question is quite open to anyone of you. Anyone of you can pitch in.
Yes, doctor. I think anything more than 110 is probably safe for me to start with. So if it's more than 110, I'll certainly start with, if it's ramipril, I used to start with 2.5. If it's more than 100 and if output is fine, then maybe I start with 1.25. So 2.5 if it's more than 110, if it's above 100, and if there's no significant heart failure, then 1.25. And up titrate, pull them up to 2 weeks and then start up titrating them. That's probably my standard of treatment.
Okay. Dr. Anand?
So yeah, I think I would also go with the 110. 110 is a safe, reasonably safe blood pressure to go with. I generally use perindopril, actually, 4 milligrams of perindopril. Honestly, because earlier on, ramipril patients enter, of all the ACEs that I have used, ramipril is the one which has caused the dry cough side effect predominantly. So we have kind of switched to perindopril, which at least we don't have a lot of side effects. And so we usually start with 4 of perindopril, which is usually tolerated, and then we up titrate depending on how the patient tolerates it.
Okay, Dr. Suresh?
Seems like more than 110, I would start with a 2.5 of ramipril, and then apply it to twice a day. The BP is good by the time of discharge or during the first follow-up.
Okay, while on this, just deviating from the post-MI scenario, all of us would be probably managing inpatient heart failure. Would you apply the same systolic pressure as the cutoff for starting these drugs in heart failure patients who are admitted with worsening or acute decompensated, or even a lower systolic? Because time and again we have seen our patients, most of the times we were not able to initiate or uptitrate because most of the time their systolic blood pressure is hovering around 80 to 90. So your view on that?
In heart failure, I would start with when the systolic BP is more than 100. I would like to start with a half dose of RNA, that is 50, half 25. And if I think the patient is not tolerating, I would first start with a night dose. Then if the patient is doing okay, then I start with the morning dose. That's how I do. So when starting the RNA, even in more than 100, I start with a half dose of 50. We'll start with the RNA as soon as possible, along with the decongestive therapy.
Any other comment on this, or shall we move on to the next one? The thing is, we always base these biomarkers, especially the NT-proBNP in patients who present with a heart failure. Do you think we'll initiate the RNA or ACA based on the NT-proBNP level, or you don't choose based on that? Question is open to Dr. Ramkrishna Kumar or Anand or even Suresh.
So NT-proBNP now it's a marker which is used for diagnosis, prognosis, and to assess efficacy. It ideally would not help you to choose a drug, RNA or ramipril. So that is purely based on the clinical situation, EF, or on the clinical guidelines. I don't think the lab report can help you to choose over the drug. The lab report is helpful only for you to diagnose, prognosticate, or to assess the efficacy of the drug. The Paradise MA trial also clearly showed that the event rate with both ramipril or RNA was the same, though the significant reduction of NT-proBNP was shown with drug. It did not translate to any event reduction. But in a subset of patients, the STEMI patients were found to have more NT-proBNP than the other subset because of microvascular dysfunction. So when they took that substudy, they probably felt that RNA will probably fare better than ramipril in that subset of population. But then again, I don't think it boils down to the NT-proBNP. It boils down to the clinical situation of STEMI, the significance of heart failure. So we should probably stick on to what the guidelines say. The guidelines says that as of now, RNA can be started de novo, or in those patients on safe drug of ACE inhibitors, RNA can be substituted for ACE inhibitors, and probably that should guide our treatment rather than the level of NT-proBNP.
Message is very clear. Anand or Suresh, do you have anything to say on this?
Completely agreed with you, sir. We can't decide a drug based on NT-proBNP. I totally agree with Dr. Ramkrishna Kumar, sir.
So my take on NT-proBNP in general is, honestly, I am finding it less and less useful in general in the practice is how I would put it, because as we know, it's very, it is not specific. And then there are umpteen conditions where BNP can be elevated, as we know from our general experience. It is an inflammatory marker. It goes up with sepsis and ARDS and acute kidney injury. And pretty much any inflammatory condition, BNPs can go up by itself or secondary to it causing LV stretch due to hemodynamic changes. So in general, I don't find it very useful. The only scenarios I think it is useful is if a patient comes with, let's say, dyspnea without a lot of other multi-system involvement. There's clearly no sepsis. source or anything, and then you want to differentiate it from a, let's say, respiratory dyspnea versus cardiac dyspnea and so on, maybe it will help. And then obviously it has a very good negative predictive value. So in that case scenario, it might help. And for serial follow-up of heart failure also, I'm not so sure. Well, let's say if there is a very recurrent heart failure patient whom you're kind of very closely following up on, who keeps on coming back with recurrent heart failure, in such scenarios, maybe it might be specifically be useful, let's say, getting a level before discharge and finding out what their pre-discharge baseline is. And then if they come back with a so-called heart failure episodes, repeat value, maybe. But in general, I'm actually finding PNPs less and less. That is just my personal take. Right.
Thank you, Anand. And the opinion is very clear. We don't use NT-proBNP biomarker as a deciding marker for choosing any of these drugs. Maybe it can be used to guide the therapy in terms of how you are able to decongest the patient, especially as was pointed out by Anand. There are a lot of comorbs which these patients will have CKD or a respiratory infection which can alter, and so we don't go by the NT-proBNP value for choosing. Let's move on to the next one. Question to Dr. Anand and Suresh. If you can comment on what do you think about the second scenario, patient scenario that I gave you, an ACS NSTEMI, whether he had a revascularization or not. Will you be starting all these patients on AC inhibitors or RAS inhibitors to get the mortality benefit? What's your comment on this?
Unless the patient had LV dysfunction or the patient is diabetic, I usually don't start on ACE inhibitors or AR base. So only with ACS without LV dysfunction and patient is not diabetic, I don't start personally.
Dr. Anand?
Right. So that is pretty much the same. I think obviously the best benefit of ACE inhibitors is in terms of reverse remodeling, improvement in EF and LV size. So if you don't have at least moderate LV dysfunction, there isn't much to gain as far as heart failure or LV is concerned. But then we do know that ACE inhibitors per se is actually a very good antihypertensive, and it does have some, I think, pleiotropic effect in terms of anti-atherosclerotic properties. So I don't think there's a harm in using it, particularly if the blood pressure is very high, the patient is diabetic in terms of nephroprotection. So overall, I think it's a very good drug. We don't have, per se, it may not be indicated for an ACS, irrespective of if the patient had revascularization. But yes, definitely if the LV dysfunction is there, and if the blood pressure is high, if the patient is diabetic, there is definitely benefits. And I would have a low threshold in picking ACE as an option as far as hypertension is concerned and for nephroprotection in diabetic patients.
Dr. Ramkrishna Kumar, do you have anything to say on this?
Yeah, it's similar to that. With LV dysfunction, certainly it has to be used. If LVEF is normal, as said earlier, I like to stick on to the high-risk cardiovascular factors, presence of diabetes, hypertension, renal dysfunction. Probably a couple of things I would like to probably oppose CABG status or a triple vessel disease. Going based on the HOPE study with multiple cardiovascular risk factors where ACE inhibitors have proven their role, probably I will include CABG and triple vessel disease also in the risk factors in case of the EF is normal to start an ACE inhibitor in that subset of population.
Okay, message is very clear. All three opine that they'll be hesitant to start an ACE inhibitor or any RAS inhibitor in a patient with an ACS who has had a revascularization or not, but having a preserved ejection fraction. But provided they don't have any other comorbs, but most of our patients do have quite a chunk of percentage of diabetes or hypertension or CKD is quite high. So the chances of them being on these drugs is quite high. Having said that, what are your practice tolerance of an ARNI of 200 milligram twice daily? many times we feel that we are not able to up titrate because of very many reasons, be it increase in creatinine, hyperkalemia, or the hypotension. These are the more common factors which prevent us from going up the recommended dose vis-a-vis ramipril 5 milligram twice daily. So what's in your practice, what's the percentage that you are able to go up to the evidence-based dose? Question is open.
In my case, probably it's less than 10% to who tolerate a full dose. Most of them tolerate 100. The 200 mg dose, there's a lot of them who don't tolerate. So my numbers are probably much lesser.
What is the reason? Tolerate means, you mean the pressure?
Hypotension and hyperkalemia being the two most common things.
Okay. Oxidation on
Same, sir. Like hardly 10 to 20% of them tolerate the full dose of RNA. Especially young people who are already hypertensive, they may tolerate 200 twice a day. But many of our Indian females and the moderate to thin-build males, I hardly seen tolerating 200 twice a day.
Okay.
My take is, do we really need 200 BD for the best benefit? I don't think we need. I think Paradise was predominantly a Western trial. The demographics was predominantly probably heavier people from the West. And as we all know that there is an optimal dose which gives you the most benefit. And I think I'll be happy if I can get them to 100 BD. They will get the most benefit, and maybe the incremental benefit of 200 over 100 may not be proportionally that high. And then cost is also a factor. I usually give 200 half, 0 half. So there is some economic benefit also in terms of that patient. So in terms of the yield, I think if we can get them to 100 twice daily, that is reasonably good, is what I feel. And again, yes, less than 20% of patients are probably on reach a dosage of 200 twice daily.
Yeah, so this point is well taken. We do come across a lot of these factors which prevent us from going up the recommended dose. And as was pointed out by Dr. Anand, the incremental benefit of doubling the dose versus the level at which you can have all the GDMT on table, the effect is definitely, if you have all on board rather than having a max dose, the effect is going to be almost not much different significantly in terms of 100 BD versus 200 BD versus 100 with other GDMTs. This point is well taken. We do have the reasons why we are not able to up titrate, though we would love to. Versus since the arrival of RNA, before that we were using quite a bit of ramipril, we were able to get to this recommended dose in most of the patients. Actually, ramipril 5 milligrams, we were able to do that. In RNA, maybe because of the factors that we mentioned, we are not able to get into the dose, even though the dose that we can achieve will have a definite advantages or a significant MACE reduction strategy and advantage. So my conclusion, my concluding remarks will be that RAS inhibitors are pivotal in post-MI management, and they have been shown to reduce the MACE, including the all-cause and cardiovascular mortality, especially in patients with a large anterior MI, especially in patients with evidence of heart failure, and in patients with hypertension, diabetes, or chronic kidney disease. Among the RAS inhibitors, the choice is based on individuals. Most of the questions that we asked, I think the response was the individual patient profile makes the choice of the drug that they're going to give. As of the evidence base, we would route to, currently we use ACM as the drugs of choice. If they are not able to tolerate the ARBs, and RNA are still on the off-label indication, I would say, in terms of an acute MI, post-MI scenario. So with that note, I thank all the panelists and the MQ for having a wonderful this thing. Thank you, one and all.
Thank you, sir.
Thank you,
Before
sir.
we
Thank you.
close, I would like to express my sincere gratitude to our esteemed moderator, Dr. K. Samasivam, sir, for delivering the excellent session and driving the interesting panel discussion. I would also like to thank our expert panelists, Dr. Ramkrishna Kumar sir, Dr. Anand Pillai sir, and Dr. Suresh Yera sir, for sharing their knowledge and expertise with us today. I would also like to thank our esteemed audience for their time, continued love, and support for the Cardio Colloquium program. On behalf of MCure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at MCure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you.
Good night.
Thank you, sir.
Good night. Thanks.
Thank you.
Can I end now? Sir, can I end now?